everybody. My name is Mandeep Dhaliwal. I'm the director of the health practice at UNDP. Actually, I'll just speak from here. The podium looks a bit crowded. We want to have an interesting and interactive session, 2 hours on transformative digital technology for future health. We're going to unpack how how digital and technology intersect with geopolitics, human security, polycrisis, many of the things that we heard about this morning in the opening of the session. We've got a very exciting and engaging collection of speakers and discussants who will be engaging, but we also want the audience to engage. So we want it to be as interactive as possible. And we're going to start with using Menti, which I think many of you have probably used in other contexts. And if you can log in by entering the code at menti.com, then you'll be able to participate at various points in the session. And before we get started, we wanted to ask you to log in and respond to 3 questions. The first question is, what is your favorite digital health technology? The second question is, what is your biggest hope of using digital technologies for health? And then the third question is, what is your biggest fear of using digital technology for health? So you can just scan the QR code and enter the numeric code to have access. Fantastic. Okay. So let me just run through the questions one more time. What is your favorite digital health technology? What is your biggest hope of using digital technologies for health? And what is your biggest fear of using digital technology for health? So I'll just give everybody a couple of, maybe a minute or two. And as you're doing that, let me just go over some housekeeping. We're recording the session. We've got some rapporteurs in the front row here who are also taking notes of the session, and will hopefully what we talk about will make it into the summary of the meeting. We would really like you to also use the Menti link to share any comments or questions. There will be live tweeting. In addition to this, the summary that's being produced by the rapporteurs, apparently there's also going to be an artificial intelligence generated summary, which could be quite entertaining. So while you guys are looking at the results of the Mentimeter on the first 3 questions, it's interesting that nobody's got AI. Wearables are making their way up. Shall we look at the next question? Biggest hope? Increased, maybe people haven't gotten to the second question yet. There we go. Increased access, that's great, and better data for management. Okay. Looks like increasing access is winning out in terms of hope. Fantastic. Let's go to the third question. What's your biggest fear about using digital health technologies? Lack of infrastructure, increased inequities, fewer concerns about privacy. That's interesting. So infrastructure. And we're going to hear from one of the discussants about digital public goods, and I think this will come up. I was chatting to somebody from the Ministry of Public Health from Thailand this morning who was saying that one of the reasons that they've been able to really introduce digital here is because of the stability and the quality of the infrastructure, both in terms of the internet and power supply, So infrastructure is really, really important. Yeah, okay, fantastic. And any other questions or comments? If you don't feel like you want to come up to the microphone, we'll be monitoring questions and comments in the Menti, and we'll have our colleagues from HITAP who've co-organized the session during the discussion maybe feed those questions into our interaction today. So just to reiterate, what we're hoping to do is have a really good discussion about the potential and the risks of transformative digital technology for health and for the future of health. And this is really important for us because the next PMAC is going to focus very much on digital health technology in the era of AI. So I think what we discuss today and what we talk about today and learn will really help us help us to shape and maybe structure what we next year's PMAC. So I think an important discussion for us. Before we kick off and we move to the speakers, I want to just kick off with a few introductory reflections. There's no doubt about the promise of digital technology. It can transform healthcare delivery, improve health and development outcomes, and advance health equity. It has immense potential for achieving and driving universal health coverage and pandemic preparedness and response. The World Bank has just launched a report, I think today it came out, which estimates that interconnected electronic health records and virtual interactions like telemedicine can bring up to 15% efficiency gains in public services and free resources to address other needs. Digital technologies can also empower marginalized communities by promoting safe access to information, education, healthcare, and support. We also know that digital health technologies can help to, if designed correctly, can help to improve governance and contribute to economic growth. We're beginning to see the potential of these emerging technologies as well, like AI and cloud computing. Many of you will have seen the article about some of the reporting about AI leading to the development of a new antibiotic molecule in a very short time. Of course, it still needs to go through clinical trials, but really the potential of AI for accelerating R&D, improving treatment effectiveness through customization of treatment plans based on individual patient data, and really empowering healthcare workers. So these powerful digital tools can enable and accelerate social and economic change. And they're critical towards achieving the SDGs that are related to health, SDG 3 and others. So, and we saw a lot of this during COVID. We saw the acceleration of the use of digital technologies in a way that really helped to improve the pandemic response. But it's also, this landscape is also evolving very rapidly and is not without its peril. And we need to acknowledge both the challenges and the complexities along with the opportunities, especially taking a look at issues around ensuring data privacy, security, and non-discrimination, all of which intersect with issues of geopolitics and crises. So data security, increasingly, as we generate and use more data, geopolitical factors can be detrimental to the protection of personal data and the control of information and misinformation. And I was really amused to hear from the colleague from the Ministry of Public Health this morning, and he said, what we saw was that actually misinformation is more powerful and people rely more on misinformation. It spreads faster than information that's provided by healthcare workers. So it was an interesting observation about how digitalization can actually cause problems. We saw that there was rapid expansion of contact tracing and surveillance during COVID, and without necessary data protection safeguards, this can erode public trust and accountability. Conversely, the responsibility of managing health risks lies beyond the control of any one nation state and national sovereignty. So power dynamics, some of the things we heard about this morning in terms of geopolitics, can limit the coordination, information sharing, and timely responses to common health threats, which is an issue that we need to contend with. Health inequity. there's an enormous benefit to digital technologies that can bring improved health, but it's not equitably distributed across countries and populations. I think many of us have read over the last few years that technologies can reproduce and amplify existing biases and inequities. For example, AI relies on data that is generated and produced by human beings, and in turn can reflect and reproduce existing gender, race, and other biases. And we saw this in facial recognition technologies and some of the glitches that we saw in facial recognition technology and how it was playing out. Restricted flow of knowledge and technologies between countries and issues such as capacity and infrastructure can impact or limit the use of technologies. Such barriers to technology transfer exacerbate the digital divide and perpetuate health inequalities between countries. And I want to stop here a little bit and talk a little bit about the digital divide and the gender dimension of the digital divide, because my fear is that the discussion at the international level, at the multilateral level, as well as at the national level on transformative digital technologies is gender blind. So I think there's a real need to pay attention to gender and transformative digital technologies. So for example, the digital divide, where people, which refers to how many people actually have access to digital technologies, women are more disproportionately likely to not have access to digital technologies. Though that's changing, but that's something that we need to pay attention to as we roll out digital health technologies or digital technologies. So just, I encourage the audience to think through what does this mean in terms of the pervasive gender inequality that we see in today's world, and what does it mean in terms of the gender inequality that we see in the field of digital technology. And I'll just give you an example. We were at the IOC meeting on Sunday, where we were planning for the next PMAC, and it was very interesting how many colleagues talked about, oh, well, I talked about this theme with my son. Nobody mentioned a daughter. And that was interesting. And is that because more men or more boys are going into this field? So just something to pay attention to as you're listening today to the speakers. So let me move on to the last challenge, which I think is really interesting, is around accountability, which links to geopolitics. We see increasingly in the field of technology concentration of power and a power asymmetry with some nations and non-state commercial actors wielding a disproportionate amount of power. And there's a lack of clear accountability mechanisms, especially for non-state actors, so companies and corporations. Without the right safeguards and protocols on standards on regulation governing the ethical and rights-based use of emerging technologies and existing technologies, we can undermine our objective unknowingly, which is to create health equity, to create better health, and to have universal health coverage. So again, and the impact of that in terms of existing gender inequalities and marginalized populations, important for us to keep that at the forefront. So let me stop there, and let's move on to, I think, what is a very, very exciting lineup of speakers. And it's my pleasure to introduce, and I'll apologize to the speakers now. I don't like reading out bios. So please, as I introduce you, say one or two things about yourself. But it's my great pleasure to introduce Professor and Dr. Daniel Mumwai from Kenya, from the University of Nairobi. Daniel, you're very welcome. Do you have a microphone? No. Okay.
Thank you, everyone, and pleasure to be here. Daniel is my name. I'm a health system person and also a health economist who have a great interest in improving access through primary health care and the work on... Sorry? Okay. Yeah, so when I am not here, this is what I do. I advise our president in Kenya on health economics, as well as health investments, part of which is a transformation agenda that the country has. So I don't know whether I move to my slides and finish?
Yeah, you can use the clicker.
All right, thanks. So I come from a country called Kenya, which is somewhere in Africa. For those who may not have seen it, we say it is a gateway to Africa, so to speak. Our capital city is in Nairobi, and our president is called Dr. William Samoei Ruto. You are all welcome. It's a country where you don't need a visa to visit. So this kind of meetings, you should be bringing them there, so that you also, have these ideas and insights close to us. So today, I will take my few minutes to talk about the issues of use of technology for better health policies, what it takes or the feel from, a low-income country, which is largely in the sub-Saharan Africa. That is what we have a lot. And Kenya, which is a low-middle-income country. So I want to highlight that we are seeing the large agenda of realizing universal health coverage being anchored on several key areas. And technology is well alive in Africa, and more so Kenya, which was the first country which discovered what we call M-Pesa. M-Pesa? It's a digital platform where you can pay for all your bills on phone. I think we process our bills faster than you do here anyway. You may want to come and visit. So the integration of such technology have improved what we would call financial penetrations, even in the less privileged places, hard to reach, and also with the populations that ideally would not have been interconnected with the country financial ecosystem. And when we look at our healthcare system, we find that it is ripe for us to have a robust technology that enhance and solves majority of the issues that we have within our healthcare sector. Some of those issues that we are talking about are largely within our pillars for UHC. And I highlight that, the integrated health information management ecosystem, or what we are calling the digital ecosystem, is an attempt to interconnect all the blocks of the healthcare system in a way that they speak to each other. As of now, we find that the ecosystem is disjointed and operates, in silos. And therefore, it becomes difficult for communication and for increasing the many things that we thought can be improved with technology. So we see this technology enhancing us in terms of the healthcare financing architecture, the health commodity security and supply chain issues, and also effectiveness of the human resource for health, which of course is spatially distributed within our country, just as it is within the sub-Saharan African countries. So we do believe that technology, when enhanced, can be sweet as honey, it can be as candy, it can be as whatever you want to mention that you think is sweet. So these are just mine. There are people who actually don't think honey is sweet. So please replace the honey with what you think is sweet, so that you understand how good we are thinking this technology has ability to transform our healthcare system. Needless to mention that some of the key areas that we are looking at this technology for the sake of boosting access to care are in the issues of improving service provision. This is both prevention, promotive, curative, as well as better understanding of our epidemiological data to craft and come up with interventions that are more effective in addressing the disease burden within country, and more so reflecting the spatial distribution of these diseases within the nation. The other key important thing is relating to the robust referral system, which is also equipped with patient data portability. As of now, we have seen a big challenge where if you are moving from one hospital to another, you need to carry a physical file. If you go to the facility, then you largely would have seen a nurse with a very big register. Now, these registers actually cost millions of shillings, and of course, also require a lot of people to populate them compared to the digital solutions. The issue of administration of our social health insurance, which is a social health authority for the payments, and better launch of claim management that would improve the fraud detection capabilities, and also boost our ability to actually track and trace our commodities from the source. We have a central purchaser, but when the commodities leave the drug store at the center, it is difficult to trace whether they have reached the hospital, whether they were given to a little person, and therefore this is where we think this technology will be very important. The issue of telemedicine become also very key, and in that telemedicine, what we are looking at is improving access mostly to areas that have actually limited, access to human resource. And key among them, we have already, instituted good facilities that are using, telemedicine technology to provide care, some of which the providers of that care are based in largely developed nations, and they are providing quality solutions in our country. What I'm presenting is just a large overview of what we are thinking and what is being done or implemented for the last 1 year in Kenya to roll out the Kenya Digital Health Superhighway, which of course we began by the country developing the legal framework through which this is actually implemented. And this has been lacking for a long time, and therefore not having the right guidance actually in terms of how do we digitize. We are trying as much as we can to provide the care within one's pocket. You have seen mobile solutions are key, even in the questions that the presenters, sorry, the participants have filled this morning. So we are planning to go that route, and this is a large thing, but I want you to only note two things that are important for the probably other discussion. One, the issue of interoperable of the systems that are being utilized. The second is the issue of cybersecurity and data, safety, that this is patient data, who owns it, how is it controlled, and how do we keep the country safe for the sake of course, interconnecting. And lastly, and important, is the issue of the availability of CapEx. And this is the financial resources that are important for digitization. So I want to conclude with this last slide. And this last slide is important for us because when I look at the digital revolution that is happening, you find that there are issues that need to be highlighted that are critical for this meeting, and more important for us to come up with solutions on how to address them, more so coming from a countries that are less developed or developing. Now, one is the issue of a lack of technical resources to be able to digitize. The other important thing is a human resource, that endowment that is able to actually carry on the large digitization, investments that are happening in country. The other important thing is on financial resources, because the CapEx require, funding, and these countries are limited in terms of resource availability. Now, we realize that when we first showcased our Kenya Digital Superhighway, what began is a lot of interest from big countries, some of which wanted to digitize for free and trade with the data, some of which they want their equipment used only. So, if we are using other equipment, they don't want to support. And we also realize that, for a long time, within the healthcare system, the vertical programs that have predominantly been funded by donors have largely gone ahead to digitize. But they have used the systems and standards that have been developed by the funders. And the willingness of the funders to actually agree to interpolate and actually provide their systems for scale-up was actually limited. And this then talks to the issue of the history of how we have arrived into the digitization era, the culture that we have found within the world, and more importantly, the social inequalities that continue to be, seen within the global architecture, not only for digitization, but for other resources that are of public in nature, that would improve access and more so utilize, achievement of sustainable development goals. Lastly, I would highlight that this digitization journey has to be looked at in a way that we come up with solutions that address on how do we deal with the existing digital solutions and innovations that have already come out, and how can they be adopted and helped and scaled up in countries of this nature. Second is the resources that need to be distributed. How efficiently do we deploy the resources that have already been committed, for instance, by developing the systems that exist. And we have also discovered, anyway, that some countries don't want to interpolate even with routers from other countries. So even the internet connectivity becomes a problem because the owner is using a router that the owner of the system does not want to interpolate with or use it for connectivity. And lastly is the issue of knowledge and skills. How do we work in a way that we harness the benefit of digitization by utilizing the existing knowledge, global knowledge, and rather rely on the knowledge that is limited within the countries that are scaling up digitization for health? How do we make it right? And how do we make it sure that the sweet I had told you about will not turn to be bitter? Thank you.
That was excellent, and I think you did a very good job of outlining both the opportunities and the challenges. But some of the things that really struck me were around the need for strengthening capacity and infrastructure in country, using local capacities, resources, and really being mindful about not deepening or expanding fragmentation. Just given how health programs are financed in many LMICs. So with that, let's move on to the next presentation. We're going to come back to a lot of these issues in the discussion. Final thing, which I thought was interesting from Daniel's presentation, is he started off talking about M-Pesa, which is a big digital financial program. And I think, are there things that we can learn from other sectors in expanding digital health? From the financial sector, for example. So let's move now to Arti Raghavan, who's going to talk to us about health data and the complexities of health data across borders. You're welcome, Arti.
Thanks so much, and good afternoon to everyone. My name is Arti Raghavan. I'm an Asia House Fellow. I pursued a research project last year trying to understand how cross-border health data sharing affects digital health innovations in the Asian context. I did a study crossing 5 countries, including China, India, Indonesia, Malaysia, and Singapore. And I'll be sharing some of my findings from the research. Not all, of course, I don't have enough time, but I'll try to do my best. So let me start. So basically, last year, on my birthday, my sister gifted me this smartwatch. She felt that I need to lose weight, and she felt this is the best way she can nudge me into that. So what this basically does is, so you are all well aware of how popular this technology is, and how it helps you to keep track of the number of steps you have taken, the amount of calories you have burnt. And what happens is basically this device captures all this data by means of sensors. This data is sent to the company and a server that is managed by a company. The server collects all this data, analyzes it, and the analysis comes to me in my mobile phone in the form of, it gives me a broader picture of what I have done over the past month, positive or negative. So that's digital health data for you. And what we are seeing increasingly is personalized medicine. Just now, I also heard from one of the World Bank report launches that, personalized medicine is going to be increasingly important going forward in terms of digital health initiatives. And And today we are talking about geopolitics. So in terms of geopolitics, health data is very sensitive. Governments in Asia, they consider themselves as custodians of citizen health data. And as a result, they feel the need to protect it and save their citizens from any potential misuse of health data. Now, what this leads to basically is tying the data sovereignty principle in a way to health data and health data sharing. And that is essential, of course, because we need to protect data privacy, as has been mentioned by Mandeep as well. But there is also a lost opportunity here for healthcare sector to make use of or extract the true value of health data to begin with. And Dr. Daniel has already mentioned the many benefits, but I would still kind of broadly picture it for you, which is, I think, if health data sharing is possible at a national level and cross-border level, what it basically does is it helps improve patient healthcare outcomes, treatment outcomes. Secondly, it provides good quality data to researchers for them to come out with important findings for the healthcare sector. Third is how increasing health data sharing contributes to digital health innovations. So that is the angle I'm coming from to this topic. And the last one is how comprehensive health data gives policymakers a better picture of the healthcare ecosystem to find the gaps where they need to deploy the policies. And we have, some of the policymakers here who will very well understand this concern. But what are the challenges? The challenges are pretty systemic. When we look at the hospital systems, they find it increasingly complex and expensive to deploy health IT systems. I'm not talking about the expensive and large private hospital chains who have adequate funding, but I'm talking more broadly across Asia, the tier 2, tier 3 cities and hospitals there who want to be part of this journey of digitization. Second is, it's a major challenge for healthcare sector to hire and retain tech talent. And this is where the competition of healthcare with financial sector is in a real sense, because the financial sector pays tech talent very well, and that leads to talent attrition in the healthcare sector. And the third important one is digital adoption by healthcare providers. What happens is, for traditionally healthcare providers, doctors and nurses especially, they are not used, they have a way of working and operating in the healthcare system. And when digital is added on top of it, it leads to significant frustrations on a day-to-day level when they are delivering care. So that is also somewhere where hospitals are struggling. Another aspect, key challenge is this evolving cybersecurity threat landscape, where increasingly we are seeing hospitals across Asia being targeted to cyber breaches and hackers demanding ransom for releasing the data, giving back the data, and if the hospital is not able to or not willing to pay, the data ends up in the dark web and is sold for who knows how many millions of dollars. So that is another challenge. The third key challenge is, I would not say this is a challenge come a necessity, which is regulation. Regulations, we can see that to ensure data privacy, we need regulations. However, what happens is government tends to deploy it in a different way, which is increasingly Asian governments are going towards data localization. And what that means is data has to be stored within the country and cannot be shared across borders, irrespective of what the requirements are. During COVID, that kind of loosened up a little bit, but not completely. Governments are still there, very much there. And we see this in the form of strict data protection laws, strict cybersecurity regulations. Of course, they are necessary, but they are also in a way hindering data sharing. And the last and important aspect is the evolving global health data governance landscape. We don't see a clear framework in place for governments to follow. And this is where I think, people like, Mandeep and, Derek over here, these are the important people who will really understand this, that there is an evolving global consensus around global health data governance. However, we see two things. We lack a framework, as well as we also we don't see a coordinating body who will actually enable this process. Now, does that mean that everything is doomed? I don't think so. So I'll talk about a case study very briefly. Shot is a digital health startup based out of Singapore. I hope I'm loud enough. Yes. So OncoShort is a digital health startup based in Singapore, and what they're doing is they have deployed federated data platforms on top of cloud to enable health data insights to be collected without physically moving data out of the facility. Now, what this does is basically drawing the insights from across organizations, putting it on the cloud, and they have also deployed AI-based large language models to generate focused insights for clinicians. The broader goal is to accelerate clinical trials for cancer drug development, and they are doing a splendid job across, currently they are based out of nearly 6 countries. What this basically tells us is that cross-border data sharing is possible. Cross-border data sharing impacts healthcare, has impact for healthcare, and despite the risks and the regulatory concerns, there are ways in which technology can overcome this. Now, I want to try to convey what we can do going forward, something that Dr. Daniel also asked, what systems can do. At a national level, it is necessary for countries to develop data sharing capabilities. A lot has been talked about this over the past few days as well as today. But what really needs to be done is, irrespective of where hospitals and healthcare organizations are in terms of their health IT capabilities, they need to connect with a national digital health infrastructure, because that kind of is a beginning of enabling interoperability between healthcare organizations. That is something we are not currently seeing. For example, hospitals are not sharing data with each other within the country, across, even within regions, sub-regions sometimes. So that is the first step. Secondly, when a national digital health infrastructure is put in place, it's by default set based on international best practices, standards, and operating procedures, which means it's kind of a resilient system to the evolving threats that are out there. And these are systems that keep updating themselves, because that's in the standard operating procedures, which means these systems are a good start for health data interoperability. And once this ecosystem is ready, it is possible for innovators and disruptors to come in and to understand what the healthcare needs are and the gaps are, and to develop solutions accordingly for mainstream healthcare to address some of the challenges they are facing. This would be the horizontal integration, and this will be the vertical integration, whereby there are 3 layers at which stakeholders can make a contribution. I'm especially referring to multilateral stakeholders, because they have a huge role to play in all 3 aspects. Firstly, in terms of policy direction, it is essential for nudging governments to make policies more innovation friendly, and to effectively balance data privacy needs with the needs of the healthcare ecosystem. And this is possible when countries increasingly collaborate with stakeholders and other countries as well. At the hospital and clinical level, it is essential for multilateral stakeholders as well as other stakeholders at a national level to support upgradation of digital infrastructures and to find ways in which healthcare can retain tech talent, because they need this basically to enable their digital capacities. And lastly, for startups, it is important to bring them as part of the dialogue, because they are the ones coming up with innovative new solutions. They understand the technology, and they can kind of provide solutions that may be unbelievable at this point, but it will definitely happen. Thank you so much.
Fantastic, and I think you picked up on some important points, which I hope we're going to discuss around the need for regulation, the lack of a framework for a governance framework and regulatory framework, points about localization, and you too picked up on the issues around the need for capacity and infrastructure. Very interesting. Let's move now to Dr. Tomas Pulau, who's going to talk to us about regional engagements to digitize the economy and the implications for health systems. So moving from Asia to Europe for a regional perspective. Tomas?
Well, thank you and good afternoon. I think my presentation comes very nicely after the Asian presentation, because I will be talking about what one region is actually doing. and in the context of digital in health and economy. I'm not I'm not the European Union bureaucrat. It's very easy to get lost into very complicated legal and organizational structures there. I'm going to speak as a citizen of one of the member states of European Union, but also from a health systems perspective. Just to say 2 words about European Union, it's a union of 27 states. They are geographically adjacent. It's about 450 million people. The purpose was to create economic union where the goods and people can move freely. But more recently, it has also stepped up as a more unified voice in global politics, climate change, global health. Or using the kind of what Professor Kishore said in the opening session. So in this boat, global boat, we take up 14% of cabins, 6% of passengers, and 17% of M-Pesa digital wallet, so money to spend. So let me start. First, put it in the context. Digital in health in European Union fits into broader concept. This is one of the 6 priorities for European Commission for this mandate, 2019-2024, is a Europe fit for digital age. And health sector is included in this context because it brings benefits to its citizens, but it also creates opportunities for business, especially in biotech or digital economy, digital health in more broadly. So it's operationalized under 3 pillars: technology that works for people, fair and competitive digital economy, and an open and democratic sustainable society. And I pulled up components of that kind of are directly relevant to health sector as well, about skills, about infrastructure, about access to high quality data, and European health data space is actually singled out as specifically one of the first sectors to go for European-wide health data space. So this was kind of overall conceptualized early on, 2018, to look at, put it into context, European health challenges on one hand, the potential that digital applications and digital data can bring to improve health, and what European citizens expect. They actually agree very much that would like to see their own health data. They would also agree to share the data if it's protected. So, it's organized around 3 pillars, again, about secure access and exchange of data. The ambition is there to get the data to flow across borders. For research, we already heard that one as well, and also to empower citizens to manage their own health and their own lifestyles. More of these digital gadgets, like I have one as well. So trying to keep myself in a healthy lifestyle. So, but before we go into more detail, I wanted to a couple of words stepping back and see how health systems are organized in European Union. They are organized under subsidiarity principle. The competencies to set up health system is with member state. European Commission, European Union doesn't interfere. So we have 27 different health financing, organization, data, digital maturity level, that work, systems that work in 24 different languages. So that's the challenge. Although there is now legislation that actually superimposes on that. There is European medicines agencies and also medical devices regulation that make sure that only safe devices get to the European market. There is, especially after pandemic, much more attention on cross-border health threats and establishing something that they call health union, European Health Union, there are activities on lifestyles and issues and that address your health, cancer screening. But on the patient's rights and in cross-border, this is direct application for the digital health. It's free movement of people and right to access to healthcare. This is from 2011. There is health insurance card. Every European citizen, if they fall ill, have a right to access healthcare under the terms in that country that ultimately will be paid for by your home country. So, but there is a balance of buildings. But they can have physical access. Now the bucket becomes what kind of data will be accessible to the healthcare provider in these countries. So the European Union has already established or is working on digital infrastructure. The first applications are e-prescription and e-dispensation. And patient summaries, they are already there and up and coming. Hospital discharge reports, digital imaging reports, lab results to flow across the border. So let's see how it works. So it's this digital health infrastructure is called My Health at EU, and how it works. So if a patient from country A happens to be in country B, it goes to the health professional or a pharmacy, forgot his medicine, and needs a prescription, provides his identification. The healthcare provider can, through its domestic portals or the systems and through its own national contact point, contact the national contact point in another country that in turn has connections to their own databases where they can pull up the data. So the data is protected. Either patient needs to give consent that it allows to exchange his data, or like in my country, it's default. I can opt out, but default I don't have to give any more the permission. But the system is voluntary, it's initiative, it's an ambition. 25 countries connected by 2025. So it goes in waves. It started with the small countries, I see my own country there, for the e-prescription in the beginning, coming a little bit later in on with the patient summary. But the idea and also challenge is a voluntary nature, and it takes time. And there is also the guide in 24 different languages for both healthcare providers and patients, how the system works. So next milestone. It was voluntary, but just recently, European Council in December issued its position on a new law to facilitate exchange and access to health data in European Union. So it is now going through negotiations with the Parliament, so the ambassadors of EU countries have agreed on the position, so negotiations will start. It has two objectives. For primary use, that is the same what we discussed, the support health services delivery across borders, but also secondary use, inform health research and innovation. So in cross-border access in health data, well, it's supposed to be faster, more secure, more rights for the patients to be on command of their data. So this My Health and the EU will be expanded. Interoperability, new things that will come is that the electronic health record will now have standardized, European-wide standardized fields or standardized format that is more easily to obtain. The patient summary has like 20 information fields, so it's very limited still. Diagnosis, some surgical interventions that could be coded, that is easier. And on research, the idea is to establish a new platform for health data EU for cross-border access, and that countries would establish their health data access bodies to provide clearances for the data request and get them across the borders. So this will be mandatory, my friends, and I think that's all the European countries will have to comply over time and to make it happen. So that the countries with weaker digital maturity will have to step up. So my last slide. So where is geopolitics in all that? Well, I liked yesterday in the field visit that was framed as competition, collaboration, and transfer, knowledge and technology. I have to say there is a lot of politics inside. You're already inside European Union. It takes a lot of negotiations to come to consensus. But there is a lot of opportunities for knowledge transfer among member states, how to set up their digital health systems. But the big thing is big data, and I think this is driving it. Because 450, we have every single European member state is too small on their own to provide big data. Together, it could be 450 million. We could compete with North America, which is like 300 million. We have China, India, more than a billion people. So to start to generate big data can be used for research, biotech innovations, AI, the learning systems, you need data. And I feel that this is really the driving force. And I hope that it will be a good case study for the other regional entities that would like to do stuff. We have ASEAN, we come up, we have African Union, we have CARICOM. So I think there is, I hope in terms of knowledge transfer, that there will be opportunities to do that in the future. So thank you for your attention.
Thank you, Tomas, and I think the presentation highlights very well the potential of collaboration across member states in a region, and I think many would agree that the EU has been far in front, especially when it comes to regulation issues in the space of digital, and I think there's a lot to learn there. And the collaboration, I think, is really yielding some amazing progress. And the issues around data, and I think this is a very interesting question about big data. And then, big data is increasingly seen as a commodity. And how does that relate to the corporations? How does that relate to governments? And how does that relate ultimately to individual beneficiaries? So something maybe we can come back to in the discussion. Before we go to the next presentation, I just was wondering if I could call on my colleagues from HITAP to maybe share if there are any questions or comments that have been put into the Menti that we could just listen to now. So over to you, please.
Thank you very much. Wonderful presentation, once again. There are two questions. The first one is, can initiatives like OncoSpot work in low and middle income countries, given resource settings? That is the first question. Second question is, how does the EU law, like GDPR, affect the data sharing across region?
Okay, fantastic. Thank you. So that's for Arti and then maybe for Tomas. Yeah, Arti?
Okay, so OncoShot is a kind of an initiative which you can say that in the healthcare space, particularly, there is the excitement is starting in terms of federated data platforms. The interesting aspect is that it fastens the process of cross-border health data sharing. Given that, what I know about OncoShot is that they have been collaborating across 6 countries with different organizations, and they're rapidly expanding their partnership. So at this point in time, it is like between organizations, they are building a synergy kind of thing, so which in a way in which data can be pooled in a meaningful way for an important treatment outcome. So when it comes to low and middle income countries, it is definitely challenging if we consider whether at a hospital level, the organization has cloud computing capabilities. That is where the challenge would be. But in a situation where they are able to set up a basic data pooling kind of a mechanism, they are able to put up their data on the cloud, then it is possible for them to collaborate with startups like this to start getting the benefits of such an innovation.
Well, I think Mandeep, you already mentioned, European Union is really strong on data, I think, and the European data laws govern overall. And I think the key points are there that to protect the privacy and personal data, it's very clear, it's already indicated that it's a person who is on control. Consent needs to be given. There will be likely to be some ways how this can be given. Right now, every country decides themselves vis-a-vis the health data already mentioned. And the idea well, of course, in the big data aspect, it's about anonymized data. But this, I mentioned that these health data access bodies that countries would need to set up under this proposal, they would have to vet also the data requests that come that would use. But it's already happening. I think one of the initiatives that is already happening is this 1 million plus genome initiative that is already bringing the member state data together.
Fantastic. And I wanted to add one other thing which hasn't come out explicitly is the angle of young people. And I think young people view the question of who owns data and how data is used, and even data security and privacy issues differently perhaps than older people, because I think they don't think twice about these issues, because it's so much part of the way that they are what they're exposed to, and their use of smartphones and technology. It's different. So I'm wondering, and maybe we can come back to this in the discussion, if people want to reflect on, is this a generational thing as well, in addition to that. So let's move on. Are there any other, let's take 2 more questions, and
Yes.
then we'll move on to the next presenter.
The next question is, are there any initiatives to reduce the digital divide? And how are donors sharing the landscape of DHTs in Kenya? Thank you.
Okay, fantastic. Let's start with the Kenya question.
Thank you. I think from where I look at it from, there is still a huge disparity in terms of willingness to actually reduce the gap. But I would think that probably as time goes and, big brothers find it worthy to actually scale down the knowledge to developing countries, and more importantly for them to also become part of the global interconnectivity. And I expect that if you move from the interconnectivity of the digital health systems within the continents, from countries you'll go to continents, and therefore we hope that these countries will not actually be left behind. I did not get the question on sharing something.
So there was a question also, there was the first question, do you want to repeat that? That was on digital infrastructure, right?
Yeah.
So, yeah.
How are donors shaping the landscape of DHTs in Kenya?
Yeah.
Thank you. I think I highlighted this one in the beginning, that for a country like Kenya and actually the sub-Saharan African countries, you know that the health system is largely donor funded, and more importantly for vertical programs. When I say vertical programs, it's malaria, TB, and HIV largely. We can add, vaccines and reproductive health programs, probably in that order. And there is a lot of protectionism, because these donors are vertical. They don't speak to each other. Sometimes I don't think they like each other even. So they are not willing largely to open up. And I listened to, for instance, the HIV team arguing that by opening up, you will clog our system. It will not be able to respond to the way it has been responding. But more importantly, remember also, there are protection of jobs. There are those who view the digital openness as a way of reducing employability of some of the human resources that have ideally been working on this space. And when I look at the the referral system that is paper-based. People are thinking that you go to the, digital-based referral systems. What happens to the industry that actually produces this? And health sector is a large pusher of big registers, that are actually produced by also interested private players within the market, some of which are interconnected with the donor partners. But with the DPHK, we as a country have continuously engaged with the need to see how do we get a solution, one on how to interpolate the systems, scale up the systems that are worthy scaling up because they are there, that have open standards, but also how do we decommission those that will not be speaking to the entire health ecosystem, which they need to be part of. So it is a negotiation. It is probably smaller than the EU inter-country negotiations, but I think it's more intense and touches into the core of why some donors receive funds from those that funds them. Thank you.
Thanks. Tomas, did you want to come in on this? Yeah.
I just wanted to make one comment on digital divide. I think we usually discuss this divide in terms of socioeconomic status or gender, as you mentioned, but I think in this space, the generational digital divide becomes important. I think, and then this is something for European Union to figure out. I think the elderly would have to give agency to their family members to help them to perhaps benefit from the opportunities that come with digital health.
Thank you, Tomas. I think that's a really important perspective. I mean, I brought up the young people, but I think there is an entire generation of people for who QR codes are just a mystery. And how do they access? And I think that's a really important, very important point. Okay, let's go on to the next speaker, and then we're going to come back. I'm really delighted with the quality of the questions. I think we're going to have a very interesting conversation after we're done with the next presentation. It's my pleasure to introduce Lo Jierong, who's going to talk to us about the integrity of technology in the global context and the implications for the health sector. So how do we ensure a stable, secure, and unified global internet, including net neutrality and global cooperation? So over to you.
Thank you. Hi, everybody. My name is Jack. I'm based in Singapore.
Yes, the microphones, I think they're...
Maybe I got the bad mic. Okay. Test. Is this better?
Yeah.
Yep. So I'm based in Singapore. I work for an organization called ICANN. It's an acronym. It stands for Internet Corporation for Assigned Names and Numbers. I head the regional office covering the Asia-Pacific office. And our mission is to keep the internet open and free. So it's very strange for when the organizer reached out to us to invite us to attend this conference, because when we looked at it, it was like, it's a healthcare industry conference. Then we are from the tech/ICT space, and how are we related? But the theme of the conference and listening to this morning's speeches and the topic of this session got me to realize actually we might be able to learn something from each other, because a lot of the key words that the speakers on this panel are using are exactly the same keywords that we're talking about, same challenges that we are facing. And increasingly in the global context, there is a blurring of the lines. In the past, healthcare is healthcare. You do your thing, tech is tech, they do their thing. But increasingly, this is not the case. We were talking about digitalization. Every company or organization is digitizing. We're talking about big data. For big data to happen, you have to have internet. Then we talk about artificial intelligence, you have to have internet. These are internet-enabled technologies. Then we also talked about open standards. So in my presentation today, I will share a bit about these areas and share with you my world and the challenges we're grappling in the context of geopolitics and regulation as well. And increasingly, we need to help one another, work with one another. And I'll echo some of the points that RT made as well, where you have to have different stakeholders come together and perhaps think about what's the future of our governance model, whether it's healthcare or internet, or perhaps both of them are kind of jumbled up together. So this is the topic about maintaining the integrity of technology. But I'll start off with internet first, because everybody actually have very different understanding of what internet actually is. The Cambodian government did a survey with their citizens, and they asked, do you use internet? And most people checked no. And then they asked, do you use Facebook? And everybody checked yes. But actually, so to let people understand what internet is, it's actually not the 3G or 4G or Wi-Fi that you are using. Internet technology is actually the technology that enables your device to connect to my device, and we need three things to do so. One is we have to code our computers to all speak the same language. In other words, in technical speak, we use the same protocols. Every device must have an address, and they are internet protocol addresses, so all of your devices have an address. That's why you can connect to the internet. And because humans cannot remember IP addresses, we use domain names. You have to have a name. So you can remember facebook.com, google.com easily, but you wouldn't remember like 193.111.4.5, right? And these three things are actually called unique identifiers. They are the underlying infrastructure for internet. And it's very interesting because these unique identifiers, the infrastructure, is not maintained by governments or group of governments. They're actually maintained by people, by a non-profit organization, which is my organization, and actually multi-stakeholders all over the world. So the model of internet governance is a model of volunteer-based global cooperation, and we call it multi-stakeholder internet governance. Now in ICANN, our role is we coordinate the unique identifiers like I mentioned, and we set the policies regarding domain names. For example, when we were first established, the very first problem we had was, what if Mr. McDonald from Ireland bought McDonald.com before McDonald's the company bought McDonald's.com? Trademark is jurisdiction-based, but domain names are not. It's global. There's no borders behind it. And we had to come up with a policy that would resolve disputes regarding domain names. And the short answer to it was, yes, if Mr. McDonald bought McDonald's.com and didn't make it into a McDonald's website, it's okay. He can hold on to the domain name and use it for whatever purpose he has. Likewise, when it comes to IP addresses, how they are distributed, and also the protocols, how large should a packet size be? What's the port number for email or browser? What is the IP address system that we should be using? These are all defined by the Internet Engineering Task Force, and they are made of volunteers. Anybody who's interested can participate. And they have set thousands of internet standards from the time they have been established, and until today, we are still using the same standards that were established.
As I listen to it, I'm listening to an earlier statistics we heard in opening plenary sessions that talked about how much.
So it's interesting that we have a model which is like that, where it's not any one person, government, organization is maintaining and evolving the open standards of the internet.
Refugees.
And
to what extent is there any effort, or has there been an effort? People are fleeing or leaving their homes. As you say, they do not want to leave their homes, but they're looking for a better life. The investment in the economies of those countries and improving the economic opportunities, to what extent there have been efforts or are efforts under discussion to increase the
it's from
economic
next door.
chances for those people to remain in their own countries? This is above and beyond all of the conflict issues, but
Okay, I'll try my best to keep things interesting for you and stay engaged. Now, so traditionally, actually, if you look back in history, just 30 years only, in 2000, nobody really cared about email. And then we had the dot-com boom, dot-com bust, nobody cared about it. So nobody really cared about the internet space very much. But when we fast forwarded 10 years later to 2010 with 3G and apps on your phones, people realized, oh no, internet is a thing. It's actually important. So then there became a bunch of issues globally tied to geopolitics and regulation that crossed into the internet space. When previously it was really, for lack of a better way of defining it, a space for geeks. So only geeks were interested in what I was defining as domain names and IP addresses and protocols. But today, governments and different stakeholders are very interested in this space. And there's increasing regulation that is crossing into the internet space as well. So it's quite different from the healthcare industry because healthcare is heavily regulated from day one. It's about life and death, right? Like nobody cared about internet. It's like, who cares? But now it is an issue of life and death as well. So a couple of issues that's been going on recently within our space has been that of data privacy. The European GDPR, when it was launched, it directly impacted us because we have a system that tells people who is the domain name owner. And you are able to find my contact details publicly. If I have jarong.com, you can actually find my address and my phone number and my email publicly. But with the GDPR, we have to redact this information. But the problem was, the same lawmakers in the European Union, when they came up with this law, they forgot to ask their law enforcement colleagues, because their law enforcement colleagues were using our system to fight cybercrime. Now they can't use the system anymore. And whose problem is it? It's our problem now. We have to think of how to create another system which allows law enforcement to use our system again. And we took a few years to eventually come up with a system, but it is our model is open for anyone to participate, so it took a few years for that discussion to happen. Another example is that of cybersecurity. So, talking about cross-border data transfer, it's tied to data privacy. It's also tied to cybersecurity as well. And increasingly, for ICANN, we don't really touch content. So, if it's illegal pharmaceuticals, we don't touch it, but we only focus on the ability for my computer to connect to your computer. But governments are pressuring ICANN to say, no, there's a cross-cut between these two of domain names and content as well. And how can ICANN deal with that? Now, these are just high-level examples of a couple of challenges with regulation. And also last point is on geopolitics, which is when Russia invaded Ukraine. Ukraine wrote to ICANN and said, Russia violated international law. A lot of countries have sanctioned Russia. Can ICANN delete .ru from the root of the internet? Well, if ICANN as an organization is a multilateral body like the UN, for example, perhaps we may have to. But because our mission is entirely keeping a single internet that all of us are using, we actually turn down the request. Because for us, having a single internet is more important than geopolitics. Now, this is where I think ties into some implications with the health sector, because increasingly, I think a lot of the issues that you are facing, especially when you adopt technology, are the same issues that I've talked about earlier. And we have to find a way to actually be able to collaborate and help one another. Within our space now, every day we are worried about the internet fragmenting. A country or a group of countries, if pushed to a corner because of geopolitics, like this morning we're talking about it, if pushed to a corner, they will set up their own intranet and separate themselves from the current internet that we have. Then all the hopes and dreams we have about artificial intelligence or transferring data, big data analysis, we will lose all of this capability, because if I have so much big data, I can't process it from my country, I could send it to Singapore, I could send it to Japan, and they could process it with their supercomputers now with internet. If we have no internet, we can forget about that. So in our space, we are working very hard to make sure that the internet is not fragmented, And actually in the healthcare sector, when you are using the same technology, likewise, you actually face the same challenges. And I think it becomes a model for us to think about how can we collaborate between sectors increasingly, when in the past it is healthcare, tech is tech. But now I don't think it's the case. And ties back with a few points that RT made as well, like, when it comes to open standards or data transfer, should there be a coordinating body that looks after this? And perhaps that coordinating body also should not be one that is, can be influenced by geopolitics. And that's something that all of us have to think about. I don't have the answers to that, but I think as a starting point is creating this network and understanding how each of us use technology in different ways and why it's important for us. And by doing that, we maintain the integrity of the technology that we can all benefit. I think we've reached a point where actually reflecting, internet is an accident for us because it goes against how humans are incentivized to create and innovate. If I'm developing AI technology, I want to make sure it's proprietary, right? Everyone uses what I created, but internet wasn't like that. Internet was developed in such a way that anyone is free to join, anyone is free to connect. And it's the one single accident of history that we have benefited from, and we have to find a way to work with each other to keep it. Thank you.
Highlight a couple of things, the unintended consequences of regulation. I thought the point that you made about law enforcement, as the impact on law enforcement as a result of GDPR, I think is a cautionary tale for us to think about. But also, it's an extraordinary tool that has transformed the world, the internet, but it's also facilitated polarization. And there's the threat that you pointed out about protectionism and countries turning inward, and the impact that can have on the potential of some of these exciting new tools like AI and big data. And again, coming back to the person I was talking to this morning from the Thai Minister of Public Health, who said, misinformation spreads faster than anything else. Also, sadly, facilitated by the internet. So I think looking at, intended and unintended consequences of technologies and the regulation of them is really, really important. So let's move on to the last presentation. It's from Dr. Gary Marcus, who's not with us today in person, but has recorded a video, and it's a presentation on generative AI, looking at issues of health and also policy governing AI. So can we have that presentation? And our neighbor sounded very much like Gary, so that's why I thought it was him already. But
Which weighs more, 1 kilogram? Hi, I'm here today to talk about generative AI, health, and global AI policy. My name is Gary Marcus. I'm a PhD and an AI expert, but not an MD, and I want you to know that. The AI that we have today is not the AI that we should want. It often gives truth mixed together with complete nonsense in completely fluent paragraphs, and that's dangerous. Here's an example. Which weighs more, 1 kilogram of bricks or 2 kilograms of feathers? A system like ChatGPT will give you some long, fluent answer, but might give you, in the end, something that says something like, but in air, 2 kilograms of feathers would weigh slightly less than 1 kilogram of bricks. You never know what you're going to get. Sometimes it's true, sometimes it's not. It depends on the wording that you use to ask. These things are accurate with some prompts and inaccurate with others. They're, in the end, just not to be trusted. AI, of course, has a very long history of overhype. This goes back to the earliest days in the 1950s, and it's continued in recent decades. For example, in recent decades, we were told a number of times that we might expect that driverless Teslas would drive from Los Angeles to New York City by 2017, or that there would be fleets of robo taxis driven by Tesla by 2020. Or famously in the field of medicine, Jeffrey Hinton said, I think, and this was in 2016, I think that if you work as a radiologist, excuse me, you're like Wile E. Coyote in the cartoon. You're already over the edge of the cliff, but you haven't looked down. There's no ground underneath. People should stop training radiologists now. It's just completely obvious that in 5 years, deep learning is going to do better than radiologists. He said that in 2016. Here we are in 2024. Not one driver, not one radiologist has actually been replaced. So there's a very long history of overhype in the field. I believe that there's enormous potential for AI in medicine, but the biggest short-term risk may be under-regulation and premature adoption. On the plus side, AI can probably help immediately with things like medical transcription, which is a big win since doctors spend so much time on it. AI has begun to help with drug discovery. For example, some new classes of antibiotics were just discovered using AI. At the same time, not all that glitters is gold. Medicine has a very long history of adopting techniques without enough evidence, from trephining to bloodletting to lobotomies to thalidomide. Generative AI right now has a kind of Wild West atmosphere. There's lots of things that are being tried out, but there's not a lot of regulation. Many of them will actually work out, and some of them won't. Even the ones that work out will often need important refinements before we can count on them. Fourth, we must not give up on the goals of evidence-based medicine. We have to pay special attention to generalization. To explain what I mean by that, I'll first use an example from driverless cars. There's a function called summoning where you can press a button on your phone and your Tesla will drive across a parking lot. Somebody used this at an airplane trade show and their Tesla ran directly into a $3 million jet. This was a problem of generalization, and it's a problem of having an insufficient understanding of the world. The system had been trained on lots of circumstances, but it didn't really know what a jet was. That wasn't in the database, and the system failed to generalize to an unusual circumstance. Somebody just a few weeks ago showed that ChatGPT did terrible understanding kids' medical cases with a huge error rate. And that's because the system has been trained largely on adult data, I suppose. It doesn't really understand that children are different. So these systems can appear as if they understand everything that's going on, and yet, at the end of the day, they don't really. It's always been the case in AI and robotics and so forth that it's easy to build demos of things, but it's often hard to build systems that are robust enough for the real world. We need evidence-based medicine. We can't just say, well, the system worked really well on this one occasion. We have to really do systematic studies and see how robust these systems are before we trust them too much. My fifth point for today is that a global research collaborative, something like CERN, focused on AI for medicine would be a fantastic thing. The AI that we have today is not reliable, it's not truthful. More truthful, more reliable AI would be great. Current generative AI is just a first step. Better AI, which is going to take fundamental basic research, could lead to even bigger advances than what we're able to find today. Another huge risk that we need to watch out for is what lawyers in the United States sometimes call forum shopping. What forum shopping means in the law context is you try to find the right jurisdiction for your trial so you're likely to win. You might think this neighborhood you'll get a better jury than that one. What it's going to mean in medicine is that companies are probably going to go where the medical standards are the lowest and test on patients with the least resources, the ones, for example, that can't sue them for malpractice. This has a very negative consequence that poor people are going to wind up being guinea pigs. This is not a good thing. My seventh point for today is that we need governance, possibly including things like national and global AI agencies, governance that's agile enough to deal with technology that may change very quickly. And this is no less true for health and medicine than for any other application we might think about. In April of last year with Anka Royal, I wrote an article with The Economist saying the world needs an international agency for artificial intelligence. This is no less true for medicine. All AI for medicine technology has to be properly and equitably vetted. And the best way to ensure that all patients worldwide see the benefits of AI without suffering from excessive and premature implementation is to have shared, evidence-based international standards. And finally, my last slide. How are we going to get there to the international global research that we might need and the standards and governance that we might need? I think realistically it's going to take years. One good model for developing international governance is a recent UN interim report called Governing AI for Humanity that just came out last month. One of the things I like about it is a table, you won't be able to see it right now, but you can look it up, Table 1, where they plot out over a series of months and years steps that ultimately might lead into international treaties, but try to make some gains before treaties are founded. In the coming months, the UN is going to hold a sectoral working group that will focus in part on health. Another model to consider I'm less familiar with, but many people in this audience will know more, is the WHO Pandemic Treaty, which is also in the works. Bottom line is there's a lot of work to be done here. Aligning incentives, including a wide set of stakeholders like corporate and governmental stakeholders, but also civil society. We need a lot of scientists on board, we need ethicists, we need people representing the global south and so on. Making sure that AI for health is transformative, equitable, and well-governed. I'm sorry I can't be there with you today, but I thank you very much.
Great. So I think a sobering reality check on AI. And I have to say, one of the reflections that I think we all have to accept that human beings love technology. And so even in the field of health, we're always looking for, the next technology that's going to either improve health or make our jobs easier. And I think Gary's presentation is really a cautionary tale on how we get to that stage and what needs to happen, that we shouldn't just jump into embracing technologies without thinking about how they're governed, how they can be used, what the risks are, all super important. So let's go, before we engage with the audience, I want to go straight to, we decided we were going to do a live demo, but given all the technology glitches that still happen and the instability of the internet in this hotel, we decided that we weren't going to do a live demo, but we asked ChatGPT 2 questions. So I thought we could just show you what ChatGPT threw up. So the first question we asked was, how should digital health technology be governed or regulated for global health? And it threw up just about everything that has been said across the presentations today. And then the second question we asked, which I thought was really interesting, is how evidence-based are your responses? Let's see what it said. So it said something about scope of knowledge, recognizing that it's still training and, it's a moving target, accuracy and reliability, and it recognizes that it can provide information that is outdated, incomplete, or in need of further context, no personal experience or opinions, and interestingly, on the question of ethical and policy considerations, it talks about a synthesis of various perspectives rather than something that's based on moral reasoning or principles. So interesting. I personally have asked ChatGPT if it lies, and it admits that it lies. So I think it's very interesting. We can rely on these tools, but we have to be very, very mindful of their limitations. And I think it was coming after Gary's presentation. This is quite interesting. So let's move on to discussants. We have 3 discussants today, and I'm going to ask the discussants to share inputs, take 3 to 5 minutes on some specific things. And I'm going to start with Cecilia O, who is my colleague from UNDP. She leads our health work in the Asia and the Pacific region. And Cecilia, I'm going to ask you to talk about technologies and digital health technologies and rights-based approaches. Is there another one? See, the limitations of technology.
Okay, I hope it's working. Well, good afternoon,
Maybe
everyone.
stand up and come to the front. Thanks.
Good afternoon, everyone, and thank you to the panel. I thought that was a really interesting discussion. Mandeep's asked me the question of a rights-based approach to digital health technology. And I think maybe we should understand the question in terms of what do we mean by rights-based as a starting point? I think for many of us, we talk about rights-based approaches in the public health space, and I think it's possibly similar when we talk about other sectors as well. But essentially, the idea that it should be looking at advocating for the protection and upholding of human rights, very simply put, very general in that sense. But why do we want to do that? I think more than 10 years ago, I think UNDP was part of the initiative for the Global Commission on HIV and the Law. When the report came out in 2012, and I think Mr. Lowe was mentioning that nobody talked about the internet then, but in that commission's report, they talked about the fact that there are so many possibilities for digital health, but it also risks. And I think part of the reason why the commission pointed out to the need for greater regulation, greater caution in terms of digital health was within the context of people living with HIV. We talk about, the problems of data breaches. We talk about the problems of discrimination. These are the risks that would be associated with digital health technologies, particularly when we talk about the existence of punitive or criminal laws that would affect people living with HIV. Everything from mandatory testing to, disclosure to discrimination of people with HIV. So I think that's what we are looking at, learning from the health sector in terms of understanding the need for a rights-based approach. So that's more or less the what and the why. But then the how, I think, is also the question. I don't think we have the answers yet in terms of how are we going to have a rights-based approach that will uphold human rights, fundamental principles, because I think one of the panelists in the plenary said it's a very complex construct, governance. What is that mechanism? We need to understand what we're governing. And in this case, we're talking about digital technologies, but there's a whole gamut of them. It's evolving really quickly. We need to figure out how we do this. And I think the other question is also at which level. We talk about the national level. Of course, you want to have governance mechanisms for digital health. And I think one of the approaches that's been suggested, including by UNDP, is to look at national digital health strategies, whereby you bring together different stakeholders, you try to understand the landscape, and you try to figure out, what are the fundamental principles to help uphold human rights within that context. But at the global level, and that's, I think, something that's increasingly needed because we're talking about sharing of data across boundaries, and there are no longer boundaries when we talk about digital and data and the internet. Then we come to the problem that we are probably facing in the space of global health. What are we governing, and how should we do this? Maybe some ideas on this. I think it's the same issues. Who are the actors? What are their roles? It's got to be a multi-stakeholder type process because there's so many people, including the geeks who understand the internet and technology, as well as the public health experts, and the policymakers, and so on and so forth. And I think there's the accountability issue. We talk about cybersecurity, data breaches, discrimination. Who are we going to hold accountable for all of these transgressions? We need to figure that out. The liability issue is another thing. And then finally, I think what are we governing? Maybe it is the issue about global public goods. I mean, this was something that was reflected in the plenary as well. What is this global public goods, and what do we want to see out of them? I think there may be a couple of things that we want to think about. It's kind of having a set of standards. We all talk about interoperability, so maybe that's the sorts of standards that we need to be talking about. But also the standards in terms of, I guess, how do we ensure that there is access and equity? So the essence of digital public goods means that we will all have equal access and equal benefits coming out of this. How do we ensure this? So the governance mechanism would have to take this into account. And I think that's maybe where we grapple with. And sorry, Mandeep, I don't have the answers, but I think these are the questions that we probably need to take into account. Let me stop.
No, I think that's really good, and I think, Cecilia, you've sort of started in your articulation to show how perhaps human rights principles can help to shape a governance framework for this very complex area. So let me actually, I was going to come to Dr. Basant-Garg next, but I'm actually going to go to Alain because I think it builds nicely on Cecilia's intervention and come to Dr. Garg last. But Alain, could I ask you to speak? Alain is the Director of Digital Health and Innovation at the World Health Organization, has been leading some of the really, really important work that's coming out of WHO on digital health, and most recently on artificial intelligence. So Alain, over to you. Okay. And I'm going to ask you to talk about some of the work that you've been doing on guidance and regulation around digital health, as well as the global digital health strategy.
Oh, I see. I'm about to disrupt the infrastructure here, so that's what I've been warned. So first of all, let me thank you for this opportunity and congratulate you, Mandeep, on a fantastic panel. It's really been an enlightening afternoon with some deep discussions, and it's really delightful to have PMAC struggling with this very timely and topical set of issues. I think having Kenya highlighted on the stage is extremely exciting because with the launch of the Kenya e-Health Act last year, we've been holding that up as a model for many countries to look at this foundational question that you just brought up, Ms. O, a second ago, about what is governance. And I think the Kenya e-Health Act takes that question to heart and defines the role of a governing body for digital health for that country with a mandate, with a scope, with regulatory authorities, and a fundamental budget, which I think is the other key issue. So I think it's a model of one of these approaches to governance, which is really exciting. But I think the other theme that has emerged that resonates very deeply with why WHO has placed such a central role on digital health and artificial intelligence is really this value-first argument, right? What are the problems that we're trying to solve? But also, what does the future state look like? And it also comes to this idea of having a strategy. Having a strategy that's aligned with the national health strategy that then defines a blueprint and a costed roadmap. These are not things that exist in isolation, but they all need to build upon each other. So we need to have a vision of why we're doing this, not just digitization for digitization's sake, but where are we trying to get, what are the problems we're trying to solve, and in a shared multi-stakeholder vision of where we're trying to be in the future. And of course, the benefits need to be articulated with great clarity. Are we looking to achieve financial benefits? Are we looking at improving and strengthening supply chains? Are we looking at strengthening the person-centeredness of the care experience that people receive in the country? Are we trying to solve bottlenecks around claims accountability, which many countries find as the most convincing argument to go to the Ministry of Finance and to say, this is why we need you to unlock a new governing body around digital health. Like in India, one of the central arguments for having national digitalization is to be able to have strong accountability for public expenditure of universal health coverage funds. And so WHO has for many years been supporting digital health, e-health, telemedicine, and we serve now as the custodians of the Global Strategy on Digital Health, which is a member state document that articulates roles for us to play as a normative agency, but also things that all of you in the room who are members of either civil society or technical agencies or multilateral agencies and funders should be doing to advance the global agenda of digital health. So if you haven't seen the Global Strategy on Digital Health, it's online, happy to give you access to it, but it's really what member states have been clamoring for as they shift from a state of digital experimentation that has characterized the last 20 years of our work in digital health to this era in the post-pandemic state of digital transformation. Like we have seen in the financial sector, like we have seen in education, in agriculture, moving away from paper-based approaches to digital approaches. But what we're hearing at WHO from member states is not just help us to convert what we do on paper into a digital paradigm. What they're asking us is to say, how can we reimagine, much like the banking sector has done, much like the transportation sector has done, how can we reimagine the way we deliver health? You know, what's the Uber or in Bangkok, I see how delivery is happening with motorcycles and boxes in the back of scooters. What's that for the health system? And that transformation has been enabled thanks to digital. But I think the other piece, Mandeep, that WHO is really hearing and has become the central tenet of our work is a focus on foundations. Because we cannot continue to invest in digital experiments or digital solutions without having robust foundations. And this is something that I'm delighted to hear every member of your panel really emphasize. Governance, policy, regulatory structures, architecture, and CapEx and OpEx resources, right? Operating expenditures and capital expenditures of resourcing that's needed for this space. The conversation at the UN General Assembly last year shifted away from this towards digital public infrastructure and digital public health infrastructure. And I think that's going to be a theme that we hear, I think, from my colleague from India in just a moment. But it's a theme that countries around the globe are realizing that donor-driven investments in verticalized pet projects is not going to transform health systems around the world. And just, you know, I was, as you were presenting this landscape of fragmentation, 2023, the Gates Foundation commissioned an analysis of how much fragmentation was still existing, how much donor-based investment was being driven on the African continent, and it was roughly 50% of the projects currently underway on the African continent are driven by donor priorities. So we still have a ways to go when we're talking about breaking that landscape. So I think for us, the message is clear. Invest in foundations, build the roads and highways, and that will facilitate the cars and buses that we want to drive on it. Everyone loves to see the new Tesla, the new Mercedes bus, but we don't realize that those buses fall apart if the road is full of potholes and there's no traffic signals. So let's build the road, let's strengthen the infrastructure, let's have the rules of the road and the traffic lights, and then let's invest in the buses and cars that everyone likes to talk about. Thanks.
Thanks so much, Alain. That was brilliant. I think you can see how in Alain's short time at WHO has really, I think, made a step change, both in terms of the global digital health strategy and the new guidance sets out on regulating AI. I want to take your road analogy a little bit further before I come to Dr. Garg, and that is, you know, we have to recognize that the road is not flat. It's not level. And the road looks different to somebody who's in a city than to somebody who's in, a rural village somewhere where the road hasn't reached yet, or to someone who doesn't have access. For example, a woman who may not have access to a local primary health care clinic. So I would like, and this is a conversation that UNDP is keen to have with WHO and others, is, how do we make the equity focus much more explicit? Because it's not just about quality health care, it's about quality health care for good health outcomes for all. And the central tenet of all of this for us is, healthy lives and well-being for all. So it's not a level playing field. Not everybody has equal access to the road. How are we going to deal with that? As a community that's interested in advancing digital health. And I like the foundation analogy as well, because we need to get to scale. We can't have demos and pilots, as people have been saying. And digital lends itself to scale. But how we get there is really, really important, and the equity angle is critical. And we saved the best for last, Dr. Garg. Thank you for your patience. India has been at the forefront of, I think, some of the most remarkable scale-up of digital health technologies through routine immunization, through COVID vaccination, and now to universal health coverage. And UNDP has been working closely with the government in India on these digital efforts, along with a range of other partners. So delighted to have you here. Please, Dr. Garg, over to you.
Thank you, Mandeep, and thanks to all the panelists for enlightening us. I'm here to present a small insight into what India is doing. I am Basant Garg. I'm additional CEO of NHA, and along with that, I am also the mission director for the National Digital Health Mission. I would like to talk about, from where Alain left off, the digital public infrastructure. India has been working on digital public infrastructure, and I'll give you a very small example of how DPIs helped India to leapfrog in the sphere of financial inclusion. I'll give you some numbers. In 2008, India was probably the most unbanked country in the world, with only about 17% Indians having a bank account. By 2017, in 9 years, this number went up to 80%. So 80% of Indians, they got their bank accounts. So in 9 years, India leapfrogged. And all this without anybody understanding the technology. So nobody actually understood. Just as Lo said, we have been using internet. How many of us knew what internet means? There was an example about internet and Facebook. Similarly, in the sphere of financial inclusion, UPI helped India. The digital public infrastructure, the good, helped India to take its population and make financial inclusion possible at a population scale. Now, I would also like to give you an example of how the G20 presidency of India has been able to get the focus back on digital public infrastructure. There has been a consensus on having a global repository of the DPIs, and as we speak, India has created this global repository. India has invited people all across to come and offer whatever DPIs are available to the world at large, in line with our philosophy of offering, considering the world as one family and offering whatever we have developed to the whole population, to the whole world. Now, coming to the topic of geopolitics, I'm not going to comment on anything other than, when it comes to the voice of the global South, I think data is something which is going to give a lot of credence to the voice of the global South. Without data, I think we feel that people haven't got that kind of say in the geopolitics. But with big data and with the data availability, I feel that people from from the countries of the global south will also find a voice. Thank you.
Thank you so much. And I think that's a really, really good segue into some of the questions that we wanted the audience to think about and to engage on. And one of them is really about this question of governance, which we've talked about in terms of, the rules of the game. Who's setting the rules of the game? And how can this be made into more of an even playing field for the relevant stakeholders? How does the Global South become more of a stakeholder? How do we redress the power imbalances there? Also, this issue of other sectors. We heard about the financial sector, financial inclusion in India as well, the M-Pesa in Kenya. What can we learn from other sectors to advance better digital health in all of our countries? And how does that happen on a more even playing field? So let's throw it open to the audience. Thinking about governance, thinking about geopolitics. What are the power imbalances that we need to address? We heard about one from the G20, an initiative to try and include and be more inclusive through the G20 on digital public infrastructure. So any reflections on geopolitics? I know it seems like a big concept, but how do people think it relates to, and how can we deal with the complexities and the imbalances of geopolitics in the world today in a way that helps us to advance digital health? And maybe I think the EU model is an interesting one because it's about member states coming together, regional approaches. Maybe that's one way. The other question, of course, in the title of the meeting that we're at is around crises. How do we deal with these issues in a context of multiple crises? And certainly at UNDP, we see that digital health, digital solutions are even more important in crises contexts and can help us to reach people who are in challenging contexts. And so it's not the Lamborghini solution. The Lamborghini can actually be very, very useful in a road full of potholes, dodging air fire. So the use of digital health solutions in crisis contexts, is that something that people want to reflect on? Or if you have any other questions, maybe we can ask our colleagues from HITAP to read out some of the questions.
The first question is, are our governments and international organizations capable and appropriate groups to govern and regulate DHTs? And the second question is, how can we build capacities and competencies for DHTs in resource low setting?
Sorry, what's the acronym you're using?
Digital health technologies, DHT.
DHTs, okay. I know, I was like, oh. I always learn new acronyms when I come to Asia. Not to be confused with DVT for the medical community. But, okay, so anybody want to take, Arti, did you want to come in on that?
Can you just shortly repeat what the question was?
Yeah, so are governments and international organizations capable and appropriate groups to govern and regulate digital health technologies? And the second one, how can we build capacities and competencies for digital health technology in low resource settings?
So in terms of low resource settings, I think the benefit is that I think international organizations have already started deploying technology at the last mile for their community health workers, in very challenging environments. And there is also examples of, certain international organizations working across borders who have used technology to kind of ease the work of, public health professionals working in conflict areas, for example. So I have a friend who works with Doctors Without Borders, and he's been using technology very efficiently from the Rakhine state in Myanmar, a few years back, where he's done a lot of interesting work in reporting what the findings are and kind of ensuring that there is last mile healthcare provision. So that is where I think, that is where the international organizations come in. Where the governments come in, I think it's a very challenging landscape in Asia right now, Because when I mentioned the data sovereignty principle, right, what happens basically is that governments tend to emphasize that health data is, they categorize it as sensitive personal data in data protection legislations. And when they do that, they're also kind of developing restrictions around how health data will be dealt with. Let us say, including how healthcare organizations are using it, and as well as how they're collaborating, and how global technology and digital health startups, regional digital health startups, how they're able to collaborate with organizations in the country. So they're shaping all of that when they regulate health data. But when it comes to like the country level differences, there is a wide gamut of differences. Governments are regulating digital health very differently. Some are open to cross-border health data sharing. The Japan-EU collaboration is a good example. But however, many a times, I think in agreements, there is a gap in terms of agreements don't tend to recognize health data separately. They don't define it separately. And they kind of club health data as part of the overall data definition and don't understand the differences and the nuances of health data or explicitly recognize it. That is a key challenge. And also, if they are having an agreement with another country in terms of data sharing across borders, there is no specific process put in place on how this will exactly take shape, in what circumstances health data sharing would be possible. So there remains ambiguity in this sense. So that is also something that is happening, and this is primarily because of the politics of this, which has been widely accepted. Because when we bring in politics, there are national priorities that come into shape, and they influence how governments regulate data and how they regulate cross-border data share.
Thanks very much. So what I'll do is I'm going to recommend that we just go down the panel and ask, because we're almost at the end here, any final reflections or responses to these specific questions. So Tomas, over to you, and then we'll come to Lo and to Daniel. Do you want to pass? Okay, you've got it.
If I would say one thing is to be smart about the rules and infrastructure, I think, and also not to try to do sector specific. Some rules are really foundational for digital society, like the data laws that are in European Union, and you build on that. The same on the infrastructure. We have sometimes temptation to design, procure a turnkey system that delivers everything. The infrastructure should connect. I mentioned European Union, 27 different systems. You see, European Commission cannot impose some sort of system that to impose on the countries. It needs to connect. It needs to provide this secure highway that the data can move. Some standards to define the output of one system needs to fit the input to the highway, and then let these member states to work out that whatever they do, they produce it. So then it becomes more organic. Estonia has been mentioned often in digital society. We were successful because we didn't have money in 1990s. We really need to start with very, very basic things, the basic infrastructure, then everybody can build on that.
Thank you, Tomas. Very useful reflection.
Thank you. Just a couple of points. The first one in relation to the question about governments and IGs capable of regulating DHTs. So I think my view, and I think the point is, governments can't be the only one calling the shots. And I used to come from government. So government make regulation in such a way that it's always one step behind. So if you only leave it to government to decide, what happens is they'll always be one step behind. And then it will stifle innovation, especially in digital. So the key thing, at least the Singapore government strategy, is how do we find the middle way? We be able to govern it in some way, but we leave it open for people to innovate. And I think that's really a key principle behind it. The second point tied to this is, like Arti was saying, government will have that natural political motivation, which may be good and may be bad. Like in the case of this morning, we're talking about the context of COVID, because of the US-China rivalry, there's also in my space, the US government had specifically blocked Chinese applications and Chinese tech devices as well. So these are issues that would have problems. But tying back to the overall theme, perhaps my own takeaway from this, and it's very heartening for myself working in my space, in the stakeholder model governance structure, is that we may want to look at a model where we can involve everyone, and like Cecilia was saying that we set up, agree on the rules, agree on what is the scope, and that governance structure would build the roads and the infrastructure like Alan was saying, and then that would allow for all the innovation that will happen on the roads themselves. And I look forward to seeing that day happen, working with everybody here. Thank you.
Thank you so much. I'm not going to need to summarize because the panelists are doing such a great job of summarizing for me. So Daniel, over to you.
Thank you very much. I think for me, listening to the discussions this evening, some few things comes to mind. One is then how do we incentivize the players within the digital systems and the whole process of the digital revolutions to actually move towards willingness to be open to collaboration, and more importantly to look for solutions. And how do those solutions sit within their own intention of why the innovation came into place? Because different innovations are done, driven by different interests from the players. Now, I also want to highlight that I do believe that governments have a big role in providing the framework through which digitization should happen, and more so, when I say government, is both regional as well as, in-country mechanisms to make sure that, these are well, regulated, without losing the sight of the fact that much of the innovations are driven by the private sector. So how do we have governments coordinate the private sector as well as, make its role of establishing the legal framework which these innovations and scale-ups can actually be done? We have large mechanisms that have funded health initiatives in the past, Gavi, the Global Fund, the PEFA, among others. Who sits them down to actually, talk about a common front that makes them to actually not, you say the forum shopping, eh? I liked that one, eh? So that they actually don't do the forum shopping, and more importantly, to really allow countries to come up with solutions that solve their problems in line with why digitization is desired in each of those countries. Now, the last one, of course, is that how does that regulation, incentivizes local solutions that actually solves the healthcare problems that digitization is expected to actually solve. So these are critical questions that, I think about as I hear the members of the panel and as well as the questions that have come through. And I hope that with the time, we will all get solutions to these directions. Asante.
Thank you very much, Mike. That's great. So I think not much to sum up. I think the panelists have done a great job of summing up the need for effective and inclusive governance, the need for infrastructure that is interoperable and works across borders, perhaps a rights-based framework in thinking about how we transform the digital sector for health. And I think something which I increasingly feel uncomfortable about is that when we have these conversations, we're really not putting people at the center, and we're not putting the most marginalized and the most vulnerable person at the center. And the true test of how effective our digital transformation for health will be, in my view, is if the most marginalized and the most vulnerable have the same access. So really putting equity at the center, not just in terms of a principle, but in terms of, or maybe it's a design principle, but it's really a design principle, it's an indicator, and it must be an outcome of the digital transformation of the health sector. So really thinking about, how do we practically use rights and equity to make this digital transformation of the health sector work for everyone, everywhere. So with that, I want to thank everybody. I hope that you've enjoyed the discussion. I want to thank the panelists. I think the interventions have been excellent, and the discussants, and to the team at HITAP, led by Sadumini, and the team at UNDP, led by Cecilia. Thank you very much.
And
it's been an honor
half
to
of
be
the
here.
population
And
of
to the
Rwanda
organizers
have been
of the
refugees at the
conference.
time
Thanks
of
very
the-
much.